Morning students. So now this video is specifically for the second MBBS students who are going to give their second Prof exams in the month of July and August. This video consists of 50 explain why questions. Explain why questions are those in which you have to answer with their rationale or the mechanism of action, or you have to give the reason why this drug is used in this disease or why they shouldn't be used together. So a lot of conceptual rationale based questions are asked in the Prof exams, and this compilation I've tried to cover all of pharmacology questions. If you students have any other question in your mind which is not attempted here, then you can write in the comment box and we'll take that also. And I'm sure that this video is going to be very beneficial for you, as it consists of a bank of all the explain why questions at one place, and it will help you revise all these questions at one particular, at a place. So please go through the video and let me know in the comment box if there's anything else that you want. Question is, ACE inhibitors produce dry cough, and why losartan is free from this adverse effect. Now the first thing that you have to understand is ACE inhibitors, they inhibit what? So ACE inhibitors are inhibiting the angiotensin converting enzyme. Okay, the main purpose of angiotensin converting enzyme is to convert angiotensin 1 to angiotensin 2. Okay, so this conversion is dependent on ACE enzyme, and this is inhibited by the ACE inhibitors, right? Now, as a result of inhibition of this conversion, angiotensin 2 is not produced, and as a result there is reduced aldosterone, there is reduced sodium ion and water retention, there is reduced vasoconstriction, and that helps in reducing the blood pressure. So this is the action of angiotensin converting enzyme inhibitors. There is another drug, that is losartan. Now losartan is an angiotensin receptor blocker, and this angiotensin receptor blocker, basically it blocks the angiotensin 2 receptor. Okay, AT2 receptor को block करता है, and as a result of this blockade, angiotensin 2 is not able to act on that receptor, and so it prevents the action of angiotensin 2. Now, why they produce dry cough? They produce dry cough because there is another substance which is called as bradykinin, and this bradykinin is also metabolized by this enzyme ACE, right? So this bradykinin is a peptide which causes bronchial irritation and cough, and this bradykinin is broken down by the enzyme ACE. When you inhibit ACE, when you give ACE inhibitors, then this bradykinin breakdown is inhibited. So there is accumulation of bradykinin in the system, and this accumulation of bradykinin in the system results in cough, which is dry in nature. So that is why the ACE inhibitors, they produce the cough. Why losartan is free? Because losartan is acting at a different mechanism, right? It is not inhibiting angiotensin converting enzyme, right? And because it is not inhibiting this enzyme, so its action, this metabolism, is free of ARBs. So ARBs, they act just on the receptor, and so they are free from this adverse effect of cough, and they are preferred. So out of ACE inhibitors and ARBs, which is preferred drug? ARBs. The preferred drug is ARB. ARB is the preferred drug. Coming to the next question, morphine is avoided in patients with head injury. Now, as you all know, that morphine is a opioid, and the primary action, they are basically centrally acting analgesics, right? Morphine is an analgesic, and it is seen that morphine increases the intracranial pressure and causes respiratory depression. So if you give morphine, right, which leads to carbon dioxide retention, hypercapnia, and also cerebral vasodilatation, right? Now, in a patient with head injury के patient में अगर आप morphine देंगे, then it will raise the ICP, intracranial pressure, it will worsen the cerebral edema condition. Suppose there is some kind of hemorrhage, or there is some kind of clot, blood accumulation, so that will be worsened. It will reduce the perfusion of the brain, and it will mask the deteriorating signs of CNS, neurological status. So morphine is absolutely contraindicated in head injury patients, right? Third question, beta blockers are contraindicated in peripheral vascular disease. Now, it is necessary to understand what beta blockers are, because without understanding the basics, you cannot write the explain why answers. So beta blockers are drugs which block the beta 1 and beta 2 adrenergic receptors, right? Now these beta blockers, they mediate vasodilatation in peripheral blood vessels. Sorry, I'm beta 2 receptor mediates vasodilatation in peripheral blood vessels. Okay, so if you block beta 2 receptor, so blocking this beta 2 receptor will result in what? will result in vasoconstriction. Okay, and this vasoconstriction means it will worsen the ischemia in peripheral tissues. Okay, so now in patients with PVD, that is peripheral vascular disease, जैसे एक है Raynaud's disease, है ना? So इसमें क्या होगा? It will result in peripheral vasoconstriction, and that will result in cold extremities and pain, and it can even result in gangrene. So as a result, so beta blockers are contraindicated in peripheral vascular disease. So understand that beta blockers are blocking the beta 2 receptor, which mediates vasodilation in peripheral blood vessels, and blockade of this beta 2 receptor will result in vasoconstriction. Next question is, adrenaline is the drug of choice in anaphylactic shock. Right, now what is adrenaline? Adrenaline or noradrenaline, we can call it anything, but we prefer to call it adrenaline. Adrenaline, which is basically secreted from the adrenal medulla, and noradrenaline is the neurotransmitter which is secreted in the remaining sympathetic nervous system in the body. So adrenaline basically acts on which all receptors? Alpha 1 receptor. It acts on alpha 2 also, but here what is important is beta 1, beta 2. Alpha 1 receptor के ऊपर act करके it basically causes vasoconstriction, right? Increases the blood pressure and reduces the edema. Beta 1 पे act करके it beta 1 receptor is present on heart, and so it causes increased cardiac output and increased heart rate. And beta 2 receptor is present on bronchi, basically all the smooth muscles, so it causes dilatation. So bronchodilation reduces histamine release from mast cells. Okay, so these all activities as a result make it a very effective treatment in anaphylactic shock. And another very important thing is adrenaline is a physiological antagonist of histamine. So remember, anaphylactic shock, anaphylaxis is because of histamine. So that is why adrenaline, because it is a physiological antagonist of histamine, it will automatically block all the activities done by histamine. Next is, Sumatriptan is used in acute attack of migraine. So what is Sumatriptan? Sumatriptan is, we have to visualize the serotonin chapter. It is a selective 5-HT1B1D receptor agonist, right? Now migraine, understand what is migraine. Migraine is a kind of neurogenic inflammation that is happening in the brain. There is vasodilatation, so that results in the headache, one part. Then there is release of a lot of neuroinflammatory mediators, CGRP, TNF alpha interleukins, and they together contribute to the pathophysiology of migraine. So Sumatriptan, the first action of Sumatriptan is that it causes constriction of the dilated cranial blood vessels, right? Second is it inhibits the CGRP release from the trigeminal nerves. So this action is mediated by 5-HT1B, and this is mediated by 5-HT1D, okay? And reduces the inflammation and pain transmission in migraine, okay? Used in the acute attack. Sumatriptan is the drug of choice in acute attack. This you have to remember. If we talk about chronic attack in migraine, chronic attack, remember in chronic attack you have to use the drugs which are used are flunarizine and propranolol. I know you can't really see it here. Propranolol, other drugs like topiramate, etc. So this is the answer to be written in a question where Sumatriptan is used in acute attack of migraine. The next question is, Montelukast is not used in acute attack of bronchial asthma. Montelukast क्या होता है? What is Montelukast? So Montelukast is basically a leukotriene LTRA बोलते हैं इसको. LTRA का मतलब होता है leukotriene receptor antagonist, right? So this acts on cysteine leukotriene 1 receptor, and it inhibits the action of what all? LTB4 and LTC4. Now the question is not used in the acute attack of bronchial asthma. So acute attack में what leukotriene acute attack condition में Montelukast is not able to act because Montelukast basically is good for chronic asthma, and it is a slow acting agent, and it is mainly used as prophylaxis. In acute attack there is release of a lot of inflammatory mediators like tumor necrosis factor, interleukins, histamine. Now in acute attack there is bronchoconstriction. So सबसे पहला तो acute attack में the bronchodilation has to be done. Now these Montelukast, they are not acting on bronchus, so they are not able to have any action on the bronchoconstriction. So Montelukast as such is not very effective in the acute attack. It can be given in chronic asthma, slow acting होता है, और prophylactically it is used. So it is Montelukast is more suitable for chronic asthma prophylactic therapy and not acute attack. Acute attack में हम क्या देंगे? Acute attack में हम देते हैं beta 2 agonist, right? Which will basically cause bronchodilation. So they are the therapy short acting beta 2 agonist are given. Next is Sildenafil is not safe for patient on nitrate therapy. Now patient on nitrate therapy. Now what are nitrates? So understand the mechanism of action of nitrates. That nitrates basically release NO. सबसे पहले बोलेंगे तो they increase cyclic GMP, which increases the nitrous oxide, that is an endothelium derived relaxing factor, and they cause vasodilatation, right? So their main action is vasodilatation, which will result in fall in blood pressure, right? Now Sildenafil. What is Sildenafil? Now Sildenafil is a phosphodiesterase 5 inhibitor, and phosphodiesterase 5 inhibitor also increases cyclic GMP and increase NO and cause vasodilatation, right? And also reduce the blood pressure. Now if you combine both of them, in case they both are combined, there will be a very profound hypotension, right? And the patient can even fall unconscious. So combination together will result in severe hypotension, and so they are contraindicated together, right? So Sildenafil and nitrates, they both cause release of NO and vasodilatation, which will result in further reduction in blood pressure. The next question is, why are local anesthetics combined with adrenaline? Now local anesthetics like lignocaine are combined with adrenaline. Why? First of all, because adrenaline is a sympathetic agent. Adrenaline is a sympathetic drug, so it will increase vasoconstriction in the injected area, and this will basically reduce the blood flow out of that area, and that will prolong or increase the duration of action of anesthetics, right? So this is the first major action. So that is there. Second, it will reduce the systemic toxicity of local anesthetic, right? Now these are the reasons by which why local anesthetic is combined with adrenaline. But remember one thing, that do not combine in surgeries of end organ or end arterial blood supply. Now what are that organs? Can you name some? They can be fingers, they can be toes, penis, earlobe, right? So in these surgeries like circumcision or earlobe repair or fingers पे कोई wound हो गया या पास drainage है, and then it has to be, so only lignocaine has to be injected. Do not inject with adrenaline. Adrenaline will basically prolong the duration of action of local anesthetic and will reduce the systemic toxicity. Next question is, trihexyphenidyl is used in drug-induced extrapyramidal symptoms. Why? Now to understand this, सबसे पहले हम समझते हैं what is drug-induced extrapyramidal disorders. So there are drugs which are basically antipsychotics. Now these antipsychotics, they act on the D2 receptor, right? And they are antagonists of these D2 receptors. Antipsychotics are used in disorders like psychosis, mania, and by their action, by blocking the D2 receptors, they reduce the psychosis, they reduce the paranoia and all the symptoms of schizophrenia. Now these drugs, when they reduce the D2 receptor, when they block the D2 receptor, then certain deficiency of dopamine results in extrapyramidal symptoms, extrapyramidal disorders. Okay, why? Because there is a dopamine deficiency, and if you will see that it is quite similar to what you see in Parkinson's disease, because Parkinson's is actually a disease where there is a reduced dopamine. So here we give levodopa. Now these extrapyramidal disorders are like acute muscular dystonia, then akathisia, tardive dyskinesia, motor restlessness, all these symptoms are there. Now when there is a fall in dopamine, and because of which we have got extrapyramidal symptoms, so here what we do is we give centrally acting anticholinergics. Why? Because see, you cannot give dopamine to that patient to make the extrapyramidal disorder better, because the actual problem is with the dopamine. So you cannot give a dopamine to these patients. Now how do you correct it? So you basically try to balance out the dopamine and the cholinergic system. So हो क्या रहा है? Cholinergic, dopamine कम हो रहा है, cholinergic बढ़ रहा है. So you give a centrally acting anticholinergic to these patients, which will control the extrapyramidal symptoms, which will bring a balance. And what is the drug's name that is used? That is trihexyphenidyl, right? So this is the drug which is used. It is also, another name is benzhexol. So this is the drug which is used, centrally acting anticholinergic, used in extrapyramidal disorders caused by dopamine receptor antagonist or antipsychotics, because they are blocking the dopamine receptor in the brain, and that also disturbs the balance and leads to excess of cholinergic activity. So trihexyphenidyl brings restores that dopamine acetylcholine balance in the brain. It inhibits the muscarinic receptors and improves the symptoms. Next question is, levodopa is combined with carbidopa in the treatment of Parkinsonism. Now we are talking about Parkinsonism. So Parkinsonism में It is the disease where there is a deficiency of dopamine, right? So in this case, now because there's a dopamine deficiency, so you try to increase dopamine. Now, how will you increase dopamine? You will give Levodopa, that is the drug which is rich in dopamine. It is a precursor of dopamine. It will cross the blood-brain barrier and it is converted to dopamine. This Levodopa will cross the blood-brain barrier and will convert into dopamine in the CNS. Okay. Now, in the peripheral tissues, अब क्या होता है? जैसे ही आपने Levodopa दिया, once Levodopa is administered to the patient, then in the peripheral tissues में there is an enzyme which is called as dopa decarboxylase, right? Now, this dopa decarboxylase, it leads to conversion of Levodopa to dopamine in periphery, and so as a result, reduced amount of Levodopa reaches the CNS, right? And CNS availability is reduced. So that is why it is combined with carbidopa. Now, what is carbidopa? Carbidopa will actually, it is a dopa decarboxylase inhibitor. ठीक है? Dopa decarboxylase inhibitor है. So this carbidopa will do what? It will go and inhibit this dopa decarboxylase. So conversion of Levodopa to dopamine in periphery will be blocked, and increased Levodopa will reach the CNS, where it will be available for conversion into dopamine. So that is why Levodopa is combined with carbidopa in treatment of Parkinsonism. Okay, got it? So because Levodopa is metabolized by dopa decarboxylase in the periphery, and as a result, reduced amount of Levodopa reaches CNS. So now we give carbidopa, which is a dopa decarboxylase inhibitor. It inhibits this enzyme. In the periphery, conversion is reduced, and more drug reaches the CNS. Increased Levodopa reaches the CNS. Vitamin K is used in the treatment of warfarin overdose. Now, to understand this question, first let us understand what is warfarin and what is its mechanism. So, warfarin is basically an anticoagulant, and this warfarin, it inhibits the enzyme. It inhibits the enzyme vitamin K epoxide reductase. Okay, and by inhibiting this enzyme, it reduces the activation of vitamin K dependent clotting factors. And what are they? They are 2, 7, 9 and 10. So the activation of these clotting factors is inhibited by warfarin. So when there is warfarin overdose बोले या toxicity, so उसमें the treatment is giving vitamin K. It restores the synthesis of all clotting factors, right? And thus it reduces the toxicity of warfarin. So this is the answer in this question. So vitamin K, it inhibits the vitamin K epoxide reductase, and as a result reducing the activation of vitamin K dependent clotting factors, which are 2, 7, 9 and 10, and this leads to the action, that is the anticoagulant action of warfarin. Now warfarin overdose mein you have to give vitamin K, which will restore the synthesis of all the clotting factors and reduce the toxicity. Next is metronidazole is to be avoided in chronic alcoholics. So metronidazole is avoided in chronic alcoholics. Why? Now metronidazole ka mechanism of action, basically metronidazole is an anti-protozoal drug. It is an anti-amoebic, anti-amoebic and anti-protozoal drug है. तो it is used in amoebic dysentery में use करते हैं, trichomonas vaginalis में use करते हैं. Now metronidazole, it inhibits the enzyme, that is aldehyde dehydrogenase. Okay, and alcohol का जो metabolism चलता है, so alcohol के जो metabolism में है, there is alcohol is converted to acetaldehyde, and this is further metabolized to further non-toxic metabolites. Okay, and then it is excreted out. Now this acetaldehyde is reduced or converted into non-toxic metabolites by this enzyme. So metronidazole, when it inhibits aldehyde dehydrogenase, then there is accumulation of acetaldehyde in the body. Accumulation of acetaldehyde happens in the body, and this acetaldehyde, it results in disulfiram like reaction. Okay, so this acetaldehyde, it produces disulfiram like reaction, and what are they? That is nausea, vomiting, palpitations, and in general unpleasant effects. So that is why in chronic alcoholics, if you give metronidazole, it will result in a disulfiram like reaction, so it is avoided. So once again, metronidazole inhibits the enzyme aldehyde dehydrogenase, which results in accumulation of acetaldehyde, which is a metabolite of alcohol metabolism, and this acetaldehyde then it gets accumulated in the body, and it results in unpleasant effects, which is called as disulfiram like reaction. Okay, next, why does ephedrine show tachyphylaxis? Okay, now this is a very interesting question. सो इसमें दो चीज़ें समझो, एफेड्रिन क्या होता है और टैकीफिलैक्सिस क्या होता है. टैकीफिलैक्सिस phenomenon होता है that when repeated doses are given, then response decreases. Okay, so that the graph, if you see, it will look like this is the first dose, second dose, third dose, fourth dose, like this. Okay, now what is ephedrine? Ephedrine is basically a mixed action sympathomimetic. What does it mean? That ephedrine actually exerts its action by releasing the noradrenaline, which is stored in the synaptic vesicles in presynaptic nerve terminals. Okay, so this is what ephedrine is. Now when you give repeated doses, on repeated doses, this stored ephedrine, the stored Na depletes, and which results in a fall in effect. So this is the action of ephedrine, and that is why ephedrine shows tachyphylaxis. That when you give ephedrine continuously, it will release the noradrenaline, which is stored in the synaptic vesicles in presynaptic nerve terminals, and on repeated doses the stored Na will deplete and will result in a fall in the effect, and that results in tachyphylaxis, right? Explain why long-term use of nasal decongestants should be avoided. Okay, long-term use of nasal decongestants to be avoided. Why? Let's see the nasal decongestants. They are basically sympathomimetic drugs. Sympathomimetics होते हैं like oxybenzone, phenylephrine. Okay. Now these nasal decongestants they cause vasoconstriction in the nasal mucosa, thus reducing the congestion, right? Now, prolonged use, if you are using them for a long time, prolonged use will lead to receptor desensitization and rebound congestion, right? And that is called as rhinitis medicamentosa. And on further और भी prolong करोगे तो then it will result in atrophic rhinitis, right? So that is why they are not to be used for more than 3 to 5 days. This is what is about nasal decongestants. So these drugs, they are sympathomimetic like oxybenzone and phenylephrine, and these drugs, they actually cause vasoconstriction in the nasal mucosa and thus reduce the congestion. And on very prolonged uses, then receptor desensitization हो जाता है, and they result in rebound congestion, which is also further can result in rhinitis medicamentosa also, and so the condition will in fact deteriorate. So that is why they are not used for more than 3 to 5 days, right? Next question is, why should withdrawal of propranolol after chronic use be gradual? Okay, now let us understand what is propranolol and how does it act. So propranolol is actually a non-selective beta 1 and beta 2 receptor antagonist, right? So propranolol will block the beta 1 and beta 2 receptor. On prolonged use per, it causes upregulation of the receptors. Now when you are depressing a receptor for a very long time, then it becomes upregulated, or you can call it super sensitive, right? So super sensitive receptor हो गया and upregulate हो गया. अब क्या होगा? Now if you will do a sudden withdrawal sudden withdrawal will result in unopposed alpha mediated sympathetic activity. Okay, unopposed alpha mediated sympathetic activity, which will result in rebound hypertension, rebound tachycardia, angina, and can even precipitate a myocardial infarction. So that is why a gradual tapering is done, and a gradual tapering will allow normalization of receptor sensitivity and will not result in a rebound hypertension. Okay, so that is why propranolol has to be withdrawn gradually, because it is a receptor antagonist of beta 1 and beta 2, and on prolonged use, when the receptor is blocked for a very long time, then it results in upregulation, and sudden withdrawal will result in unopposed alpha mediated sympathetic activity, which will result in rebound hypertension, angina, and MI. Why is propranolol used in thyrotoxicosis? So now the question here is why propranolol is used in thyrotoxicosis. So as we know that propranolol, as we saw in the earlier question also, that propranolol is a non-selective beta 1 and beta 2 blocker, right? Now what happens in thyrotoxicosis? Thyrotoxicosis is basically a condition where there is hyperthyroidism, and hyperthyroidism बहुत ज़्यादा है, very high, along with the Graves' disease, and there is along with the raised T3 and T4. Sometimes it's associated with toxic nodular goiter also, and so there is increased sympathetic drive in the body also, because T3 and T4, they actually increase the metabolic rate, and hypothermia, tachycardia, all these effects are there which are specific of sympathetic system. So propranolol, and one more thing, the symptoms that are seen, so I'll write like tachycardia, hyperthermia, anxiety, tremors. So what does propranolol do? It blocks the sympathetic activity. It reduces the. So what does propranolol do? It blocks the sympathetic activity, right? जो raised sympathetic activity है उसको ये block करता है and provides symptomatic relief. Okay. One more thing it does. It also inhibits peripheral conversion of T4 to T3. So reduces the hormone levels also. So these are the things because of which propranolol is used in thyrotoxicosis. So you will first explain thyrotoxicosis, that it's a condition where there is increased hormones, thyroid hormones, and massive increase in the thyroid hormone with an increase in the size of gland, sometimes associated with toxic nodular goiter also. And the sympathetic drive is increased, resulting in symptoms like tachycardia, tremor, anxiety. And propranolol, because it is a non-selective beta 1 and beta 2 adrenergic blocker, so it will block the raised sympathetic activity associated with the disease, and it will inhibit, provide the symptomatic relief, and also inhibit the peripheral conversion of T4 to T3, thus reducing the hormone levels. Next question, why is aspirin more strongly associated with gastric ulcers than paracetamol? Okay, so aspirin, it is an irreversible. Please remember, irreversible. This is the important word here. So it is an irreversible inhibitor, non-selective होता है of COX enzymes 1 as well as 2. ठीक है. Now COX जो enzyme होता है, COX 1, it actually synthesizes protective prostaglandins, that is PGI2 and PGE2, which basically cause mucus secretion, bicarbonate secretion, and mucosal blood flow. So because of this activity, they protect the gastric mucosa, right? Now aspirin, due to its inhibitory action on COX enzyme, it reduces. So aspirin reduces synthesis of PGI2, thus gastric damage, right? And results in ulcer formation. Paracetamol, what is the difference? It does not inhibit peripheral COX enzyme, so it is safe in gastric mucosa. Safe, doesn't cause that much damage to the gastric mucosa. So this is the answer here, that aspirin, since it is an irreversible inhibitor of a non-selective irreversible inhibitor of COX enzyme, so it reduces the synthesis of protective PGI2 and PGE2, thus reducing the mucosal protection and causing gastric damage and increasing the chances of ulcer formation. Okay. While paracetamol, it does not have a peripheral action or that much action. Now, why should women on OCP use additional contraceptive methods while taking ATT? So let's understand the OCPs, and then let's understand the ATT, that is anti-tubercular drug. So anti-tubercular drug has got isoniazid, rifampicin, pyrazinamide, and ethambutol, right? Out of which rifampicin सबसे बड़ा culprit होता है. Rifampicin is basically an enzyme inducer of cytochrome P450 family. ठीक है. So what does rifampicin do? Rifampicin OCPs के अंदर जो हमारे कॉन्ट्रासेप्टिव हार्मोन्स हैं, एस्ट्रोजन एंड प्रोजेस्टेरोन, सो रिफैम्पिसिन induces the metabolism of OCPs, thus reducing their plasma level, because once the metabolism is induced, that means they are converted to non-toxic water soluble metabolites ready for excretion, right? So that is why decrease the plasma level and decrease the efficacy, and then the patient will have increased chances of contraception. So that is why the women on OCPs should not, if they are starting with the ATT, then they should use additional contraceptive method, because rifampicin, which is an inducer of enzyme CYP450, will induce the metabolism of OCPs and thereby will reduce their plasma level and efficacy, and there will be increased chances of contraception. Right? Now, why is tetracycline contraindicated in children? So tetracycline is an antibiotic, right? It is an antimicrobial, and this tetracycline has a tendency to chelate with calcium in developing teeth and bones, and because of this propensity, it also results in permanent yellow brown discoloration of teeth and also impair bone growth. Okay, hence it is contraindicated in children below 8 years of age, and also in pregnancy and lactation, right? So this is the answer. Tetracycline chelates with calcium in the developing teeth and bones and causes permanent yellowish brown discoloration of teeth and also impairs the bone growth. Why are acidic drugs absorbed better in the stomach? It's a very, very important concept that you should understand. Now, understand one thing. A drug, when you consume, ionized and okay. So, unionized forms of drugs are more lipid soluble, and so they diffuse across the membranes. Ionized drugs are less lipid soluble, and so they do not diffuse. Now, I hope you understand. Stomach has got acidic pH, right? So acidic drug will remain what? Unionized in stomach and will absorb. Basic drug will ionize in acidic pH and will not absorb. Okay. Same thing if you go to the intestine. In intestine, acidic drug. Now intestine में क्या होता है? Basic pH होता है वहाँ पे. So intestine में acidic drug will get ionized and not absorb, right? While basic drug will get unionized, will remain unionized and will absorb. So this is the whole fundamental behind this. That drugs, they get absorbed, they travel across or diffuse across the membranes when they are unionized. Then that time they are more lipid soluble, and when they are ionized, then they are less lipid soluble, and so they do not cross the membranes. So in stomach, in acidic pH, acidic drugs remain unionized and so are absorbed, while basic drugs remain ionized and so they are not absorbed in the stomach. When the drugs come to the intestine, due to basic pH, the basic drugs remain unionized and so are absorbed, while acidic drugs become ionized and so are not absorbed. Okay, so remember this fundamental concept. Why is a person taking alendronate advised not to lie down for at least 30 minutes after taking the medicine? Now, alendronate क्या होती है? Alendronate is a bisphosphonate. Okay. So this is basically used in patients with postmenopausal osteoporosis, and it basically reduces the activity of osteoclast, and so it reduces the osteoporosis. Now, this alendronate की एक खासियत है कि it is highly irritant to the esophageal mucosa, right? So if the patient after taking alendronate he lies down, then there will be reflux of gastric contents in the mucosa, in the esophagus, and which can result in GERD and damage to the esophagus mucosa and discomfort. Okay, so to avoid this, patient is advised that once you have taken alendronate, then not to lie down for at least 30 minutes. Okay, so this is the answer for this, that after taking alendronate, the person is supposed to stand, sit or keep walking, because if they lie down, then there will be reflux of gastric contents to the mucosa, and this drug alendronate is highly toxic or irritant to the esophageal mucosa. Next question is, why is low-dose aspirin used in myocardial infarction? Now, aspirin, we all know that it is a irreversible, non-selective COX-1 and COX-2 inhibitor, right? This is aspirin. Now, in low doses, it is seen that it selectively inhibits thromboxane A2 synthesis, and this is synthesis in platelets, right? And दूसरी जगह the prostaglandin, that is prostacyclin PGI2 synthesis continues, right? Now thromboxane A2 is pro-aggregatory and PGI2 is anti-aggregatory, right? So now when you give aspirin, so aspirin ने क्या करा, selectively it inhibits thromboxane A2 synthesis, and so the aspirin, low dose aspirin, it does what? It has an anti-aggregatory effect, right? Reduces the risk of thrombus formation in the coronary arteries. So this prevents the myocardial infarction. So this is the reason why aspirin is given in low doses to patients of myocardial infarction. It selectively inhibits thromboxane A2 synthesis in platelets while prostacyclin synthesis continues, and so low dose aspirin overall effect is anti-aggregatory and reduces thrombus formation. Why is diazepam preferred over phenobarbital as a sedative? So here we need to understand the difference between diazepam and phenobarbital. Now diazepam is a benzodiazepine while phenobarbital is a barbiturate. Okay. Now phenobarbital, it increases the duration of action of GABA, BZD, chloride and channel. Okay, that is increases the duration of action of opening this GABA, BZD, chloride and channel, while benzodiazepines, they increase the frequency of GABA, BZD, chloride and channel, frequency of opening, right? And it is found that benzodiazepines, they have a wide therapeutic index, they have a rapid onset, and they have a short duration of action, less risk of dependence. Okay, while barbiturates, they have a narrow therapeutic index. They are long acting. And सबसे बड़ा difference जो है, benzodiazepines have got a specific antidote, right? That is flumazenil in poisoning or overdose. So this is the biggest advantage. While barbiturates do not have a specific antidote. So there barbiturates जो है मात खावे कि barbiturates के पास अपना खुद का एक antidote नहीं है, इसलिए barbiturate poisoning अगर होती है तो then we don't have any specific treatment. While benzodiazepines, they have a very specific antidote, that is flumazenil. So diazepam is safe and diazepam is much more preferred also. Barbiturates respiratory depression भी करते हैं, CNS depression तो दोनों ही करते हैं, तो इसलिए diazepam is safe over phenobarbital. Next question is, how does morphine act in acute left ventricular failure? Now morphine is an opioid. Opioid होता है, इसकी क्या क्या actions होती हैं? सबसे पहले respiratory depression, so that is one action. Second action is analgesia. Third action is venodilation. So in acute ventricular failure, now how are these actions effective? It analgesia करता है तो it reduces the sympathetic drive. It basically reduces the anxiety and pain associated with the myocardial infarction. Respiratory depression में क्या करेगा? Respiratory depression करेगा, उससे basically reduces the oxygen demand, reduces the workload on the heart, on workload of breathing and heart. And this, by venodilation, it reduces the preload, that is the venous return coming to the heart, and reduces the pulmonary congestion also. So reduces both the things. So that is why these effects together, they relieve the dyspnea and reduce the workload of failing heart. So that is why morphine is used in acute ventricular failure, acute left ventricular failure. It first of all analgesia करता है, so it reduces the pain. Pain के कारण anxiety, sympathetic overdrive है, that is reduced. It causes vasodilatation, so that will reduce the preload, the venous return to the heart. It will also reduce the pulmonary congestion, and by causing respiratory depression, it reduces the work of breathing and reduces the oxygen demand. Okay. Explain how omeprazole works in peptic ulcer. So omeprazole is a proton pump inhibitor, and it irreversibly inhibits hydrogen potassium ATPase pump in the parietal cells of gastric mucosa. Okay, so this enzyme is basically the final common pathway for acid secretion. So due to this action, it reduces the acid secretion in the stomach, and it reduces both basal as well as stimulated acid secretion, and causes ulcer healing and prevents recurrence. Okay. Another thing is that it is also used or also effective in H. pylori ulcer and NSAID ulcer, right? So these are the effect of omeprazole. Another important thing that you should remember about omeprazole is that it is hit and run drug. Hit and run drug किसको बोलते हैं? जो कि आई इफेक्ट किया, उसकी concentration खत्म हो गया लेकिन इफेक्ट रहता है, effect will remain. So this drug is found to be effective for 3 to 4 days. The efficacy remains for 3 to 4 days even after the drug has gone out of the system. Same thing I forgot to tell in aspirin, that aspirin, because ये thromboxane synthesis platelets में inhibit कर रही है, and platelets do not have a nucleus of their own, so the fresh enzyme is synthesized after 7 days, and so thromboxane A2 in platelets there is no nucleus, so the fresh enzyme takes 7 days to be synthesized with the fresh platelet only. Once it is inhibited, then it is irreversible inhibition. So for aspirin, if you give aspirin, its effect will remain for 7 days, and that is why another thing is that if you want to do a surgery, then you need to stop aspirin 7 days before, ताकि उसका effect जाने में 7 days लगेंगे. So aspirin has to be stopped 7 days before a surgery. Okay. Why is ergometrin used in PPH? So let's understand the ergometrin. Now ergometrin is a ergot alkaloid, and this ergot alkaloid, it causes strong and sustained uterine contractions. How? By stimulating the alpha adrenergic receptors on myometrin. Okay. Now in PPH, that is postpartum hemorrhage. Basically, what happens? There is uterine atony. That is the most common reason. So in PPH, it reduces the bleeding, and because of uterine atony, there is bleeding because the vessels are not constricted. So it reduces the bleeding in PPH by increasing the uterine tone and promoting the contraction of the uterus, okay, of uterus muscles, and closing the blood vessels or constricting the blood vessels. This is administered intravenously or intramuscularly after delivery of placenta. Okay, so this is how ergometrin acts. It is an ergot alkaloid. It acts on alpha-1 adrenergic and also serotonergic receptors, and it causes strong and sustained uterine contractions. Now in PPH, due to uterine atony, there is bleeding. The vessels which are there in the uterine muscle wall, they are not able to constrict. So it reduces this bleeding by increasing the uterine tone, and it also promotes the contraction of uterine muscles and constricts the blood vessels. So that is how it is effective in PPH. Next is, why is diloxanide furuate used in amoebiasis? So amoebiasis mein now the drug we give first is metronidazole, which is a systemic action hoti hai iski, right? So it is used in amoebiasis. Now diloxanide furuate, diloxanide is basically a luminal amoebicide. Okay, so it acts on the cyst and trophocytes of entamoeba histolytica from the within the lumen of the intestine. ओके, सो जैसे आपने मेट्रोनिडाजोल दिया तो उससे सिस्टमिक एक्शन हुआ तो अमीबा वगैरह सारे मर गए, खत्म हो गए. डायलॉक्सिनाइड फ्यूरुएट इज देन गिवन आफ्टर अ कोर्स ऑफ मेट्रोनिडाजोल. सो इट इज गिवन आफ्टर अ कोर्स ऑफ metronidazole. So what will happen? It will eradicate the carrier state of patient. Carriers जो होते हैं जिनमें एंटामीबा हिस्टोलाइटिका कैरी मतलब it remains dormant, then वो eradicate हो जाती है, and it basically ensures, once you have used metronidazole, it basically ensures complete eradication. Okay, and it prevents the relapse. So that is the main use of diloxanide furuate. It is a luminal amoebicide. It acts from within the lumen, and what does it do? That it basically eradicates all the cysts and trophocytes from within the lumen, and given after a course of metronidazole, and it basically eradicates or ensures complete eradication and prevents the relapse. Next is, how does clavulanic acid benefit when it is combined with amoxicillin? So as we all know that amoxicillin is a penicillin, okay, and it is a beta lactam antibiotic. Now hota kya hai? The bacteria, they synthesize what? They synthesize beta lactamase, and this beta lactamase, it then goes to the penicillin structure and breaks down the beta lactam ring, and thus reduces the action of amoxicillin. Okay, so what we did was we made clavulanic acid, and this clavulanic acid is, what is it? It is a beta lactamase inhibitor. So clavulanic acid, by virtue of its action on beta lactamase enzyme, it will irreversibly inhibit beta lactamase. So it protects amoxicillin from breakdown and increases the action. So that is why this combination is effective, right? And now important thing that you have to understand here is clavulanic acid does not have any antibacterial action of its own. It is just an inhibitor, and so it is also, it does not have any action of its own, antibiotic action. It is also called as a suicide inhibitor because while inhibiting the beta lactamase enzyme, it basically gets deteriorated or gets degraded itself also. So clavulanic acid protects amoxicillin, and in the process it gets destroyed, and it does not have any antibiotic effect of its own. So this is the action why clavulanic acid is combined. Now the next question is, why is clomiphene used in infertility? So clomiphene, what is clomiphene? Clomiphene is a selective estrogen receptor modulator, also called as SERM. If I write it in the full form, selective estrogen receptor modulator. Okay. Now this, what does it do? It blocks the estrogen receptor. Okay. So it blocks the estrogen receptors, and as a result, it removes the negative feedback inhibition of estrogen. So as soon as it blocks the receptor, the action of estrogen is reduced, and it leads to increased release of GnRH from hypothalamus, okay, and which results in increased release of LH and FSH. So FSH will do what? It will do follicular development, and LH will do ovulation, or LH surge will do the ovulation. And when there is ovulation, a lot of ovum are released, and then it can result in fertility. So clomiphene, basically by its action on the estrogen receptor, it blocks the estrogen receptor, and so it removes the negative feedback inhibition of estrogen, and it causes increased release of GnRH from the hypothalamus and increased release of LH and FSH, gonadotropins, from the pituitary. And this will, LH and FSH, then they help in release of follicular development and release of ovum, and thus they help in the treatment of the infertility. A side effect that seen with this clomiphene use is, it is used in PCOS. It can result in a side effect that is multiple pregnancy, because there is सिर्फ एक ovum release नहीं होगा, multiple ovums release होते हैं. What is the function of dimercaprol in arsenic poisoning? Okay, very good. So arsenic poisoning में dimercaprol. Now dimercaprol is also, इसके और भी नाम होते हैं. It is also called as BAL, which means British anti-levisite. Okay, now this is what? This is basically a chelating agent. Heavy metals poisoning में आपने पढ़ा होगा. Chelating agent होता है. It contains a sulfhydryl group, right? And this sulfhydryl group binds to arsenic and inactivates arsenic, right? So dimercaprol basically inactivates the arsenic, and it makes a stable, non-toxic, water-soluble complex with arsenic, and that is excreted by the kidneys. So this is the action of dimercaprol. So dimercaprol is given intramuscularly. It is given in arsenic. Arsenic ke alawa, it is also given in gold and mercury poisonings. So that is the action of dimercaprol. So you will study about dimercaprol in heavy metal poisoning, and here you should know the other treatments also. Like iron ki poisoning mein we use desferrioxamine. Okay. Then lead poisoning mein we use calcium sodium edetate. Gold, mercury, arsenic poisoning में we use dimercaprol. And in copper poisoning, copper poisoning में आप use करते हो, D-penicillamine. Okay. In copper poisoning you use D-penicillamine. Why is glycopyrrolate used in pre-anesthetic medication? Now, what is glycopyrrolate? So first we understand what is glycopyrrolate. So glycopyrrolate is basically a quaternary ammonium anticholinergic agent, right? And so due to its action, antimuscarinic action होने के नाते, so by virtue of its antimuscarinic action, it reduces secretion secretions, prevents aspiration, and facilitates intubation. Second thing, it minimizes vagal reflexes such as bradycardia during anesthesia. And the third most important thing is it does not cross the blood-brain barrier because it is a quaternary compound. So it does not cross the blood-brain barrier. So it lacks central side effects like sedation and confusion. So that is why glycopyrrolate is preferred in pre-anesthetic medication. By virtue of its antimuscarinic action, it reduces the secretions, tracheobronchial secretions, laryngeal secretions, and so it helps in a better visualization during intubation and surgical procedures. It minimizes the vagal reflexes like bradycardia. It does not cross the blood-brain barrier and lacks central side effects. Next is, how does dopamine act in shock? This is a very interesting question, and this concept, it is a very conceptual thing, and एक बार ये आपको समझ में आ गई तो then you will never make a mistake in this. तो dopamine basically acts at different receptors at different doses. डोपामिन की ये खासियत है. तो सबसे पहले लो डोज अगर हम दे रहे हैं डोपामिन की, विच इज़ 1 to 3 माइक्रोग्राम पर kg पर मिनट. इस डोज पर डोपामिन इज स्टिमुलेटिंग दी D1 receptors in renal and mesenteric blood vessels, causing vasodilatation and improving perfusion in the renal and mesenteric vessels. Right? Moderate dose पे that is 3 to 10 microgram per kg per minute. What does it do? It stimulates or it acts at beta 1 receptors and on the heart, and it increases the cardiac efficiency. It increases cardiac output, contractility, and so this is beneficial in cardiogenic or septic shock. At very high doses, high dose that is how much? More than 10 microgram per kg per minute. It acts on alpha 1 receptors and it causes vasoconstriction, increases the TPR, that is total peripheral resistance, and increases the blood pressure, right? And so it is effective in shock condition. So these are the three important things, and that is why dopamine is very beneficial in shock. सबसे पहले तो low doses पे ये renal and mesenteric blood vessels में perfusion maintain करता है. See, any kind of shock condition, what happens is the blood circulation goes to the important organs, and जो ये intestine वगैरह में, kidney में कई बार blood supply बंद हो जाती है. So dopamine, by acting on these receptors, it maintains the microperfusion, and that is very important part, saving kidney and the intestinal organs. Then in moderate doses, it stimulates beta 1 receptors, and by acting on beta 1 receptor, it causes increased cardiac output, and so it is used in cardiogenic and septic shock. Then high doses may it acts on alpha 1 receptors, causes vasoconstriction, and increases the blood pressure, which is again effective in shock to improve the perfusion. Why pyridoxine should be avoided with levodopa? Okay, so pyridoxine should be avoided with levodopa. Now pyridoxine is basically vitamin B6, and what it does is it enhances the peripheral decarboxylation of levodopa to dopamine by acting as cofactor to enzyme dopa decarboxylase. This is the enzyme, and this enzyme dopa decarboxylase causes peripheral decarboxylation of levodopa. So that will do what? That will reduce the availability of levodopa to cross the blood-brain barrier, thus reducing the efficacy in Parkinson's disease, right? So this is the action of pyridoxine. Now that is why pyridoxine should be first of all avoided. How do we treat it? We give carbidopa. Now what is carbidopa? Carbidopa is a dopa decarboxylase inhibitor. So this actually acts on this enzyme and inhibits dopa decarboxylase, and so it increases the availability of levodopa in brain. How does it do that? Because it reduces the peripheral conversion of levodopa, right? So by acting on the dopa decarboxylase enzyme, it makes more levodopa available to cross the blood-brain barrier and go into the brain, and reduce peripheral metabolism of levodopa. So pyridoxine to be avoided with levodopa, and levodopa is combined with carbidopa for this reason. Next, why is pethidine preferred as obstetric analgesia? Now pethidine is an opioid, right? But pethidine has got lower risk of respiratory depression. Now we know that opioids, they cause respiratory depression. So pethidine has got lower risk of respiratory depression as compared to morphine. First thing, it has got a short duration of action and less effect on uterine contractions, right? So which is very important during labor. आप labor में दे रहे हो and वहीं पे अगर ये opioid आकर अगर contraction ही कम करेगा तो फिर use क्या रहेगा? Plus it has additional anticholinergic properties also. So it reduces the muscle spasms. So this helps with the labor pain. So pethidine is preferred as obstetric analgesia because of these three conditions. So this is there. One thing is important: do not overdose, because then it can result in CNS depression. So this is the answer in this case. Why are thiazides used in lithium-induced nephrogenic diabetes insipidus? Now, what is diabetes insipidus? Diabetes insipidus, lithium-induced nephrogenic diabetes insipidus. So diabetes insipidus basically is a condition where there is excessive water loss because the renal tubules, they become insensitive to antidiuretic hormone. Antidiuretic hormone is the hormone which basically maintains the water balance in our body. It reduces excessive water loss through the kidneys. In diabetes insipidus, the renal tubules, they become insensitive to ADH and lead to the excessive water loss. Now thiazides क्या करते हैं? Thiazides are basically diuretics, right? Now here they are having a paradoxical action. Paradoxical, क्योंकि आप कहोगे antidiuretic hormone को insensitive हो गए तो इसमें why you are giving a diuretic? So their action is paradoxical. How they are doing paradoxically? They basically reduce the urine volume by inducing hypovolemia. They themselves also cause a loss of water and will induce a hypovolemia. This induced hypovolemia will basically reduce the urine volume. क्या होगा? They will increase the sodium and water reabsorption from the PCT, thus reducing the volume reaching the distal nephron, distal tube, collecting tubule and collecting duct, and thus decreasing the urine output. So that is how thiazides help control the diabetes insipidus. So this is a paradoxical effect, right? So this is the answer that you have to write in this question. Explain why ranolazine is used in angina pectoris. So ranolazine is a drug which inhibits the late phase of inward sodium current, right? So that is, they inhibit the late phase of inward sodium current in cardiac myocytes during ischemia. So this is the mechanism of ranolazine, and so because of this it causes reduced calcium levels, and that leads to diastolic relaxation of the heart, that is improved diastolic relaxation and decreased oxygen consumption. So this is the action. Ranolazine does not act on the blood pressure. It does not have any effect on heart rate. It does not have any effect on blood pressure. So it is found to be useful in chronic stable angina and where other drugs may be contraindicated. So this is ranolazine. It is a drug which inhibits the late phase of inward sodium current and in cardiac myocytes during ischemia, which reduces the calcium levels and causes improved diastolic relaxation and decreased oxygen consumption. So that is why it is beneficial in angina pectoris. The next question is, explain why lignocaine is used in ventricular arrhythmias. So we need to understand what is lignocaine. Now we all know that lignocaine is a local anesthetic. We have studied there. Lignocaine, apart from a local anesthetic, it is also an antiarrhythmic. Okay, and the class of antiarrhythmic is 1B, where it preferentially binds to the inactivated sodium ion channels. So this is the mechanism. So it reduces the depolarization, and the same mechanism which is there as a local anesthetic is also applicable as antiarrhythmic. This action especially in the ischemic myocardial tissues. Okay, so this is its action. So what does it do? It decreases the action potential duration and also decreases the refractory period, okay, in the ventricles. So it is highly effective. Lignocaine, because of these actions, is highly effective in ventricular arrhythmias, okay, following myocardial infarction or digitalis toxicity, right? And it is also used in emergency conditions, emergency settings also, because it can be given IV and it has got a very rapid onset. Okay? So this is why lignocaine is used in ventricular arrhythmias. It is a class 1B antiarrhythmic and it binds to the inactive sodium channels, causes depolarization, and hence it reduces the action potential duration and the refractory period in ventricles. It is highly active in acute ventricular arrhythmias and is used in the emergency settings where there is arrhythmia following MI or digitalis toxicity. Next is, are aluminum and magnesium salts given together as antacids? So now aluminum and magnesium, aluminum is aluminum hydroxide and magnesium is magnesium hydroxide. These aluminum and magnesium salts are given together. Why? So we have aluminum hydroxide and magnesium hydroxide. How do I write magnesium hydroxide? I've forgotten. Anyway, so now aluminum hydroxide, this causes constipation and this causes laxative effect. So this constipation and इसका जो laxative effect है, ये दोनों एक दूसरे को balance करते हैं. So when they are used together, then it is seen that they counteract each other's side effects. Okay. Another thing is, when we combine them, we get a sustained neutralization of gastric acid. So इसलिए giving them together is found to be useful in cases of GERD and peptic ulcer, right? Next, why oxytocin is preferred to ergometrin in labor. So here you need to understand oxytocin and ergometrin comparison. Oxytocin versus ergometrin. The first thing is that oxytocin increases, or I'll say it induces, rhythmic uterine contractions. Okay. This induces strong uterine contractions. Here the differentiating feature is without increasing the uterine tone, while these increase the uterine tone, right? Now it is preferred over ergometrin first because it has got a more physiological, pattern of action. Means it is more related to the natural, no sustained contractions, right? It's a rhythmic contractions, just like natural contractions. Secondly, ergometrin causes hypertension, so we cannot use in situations like preeclampsia. So that is one reason. So that is why oxytocin is safe, right? So that is oxytocin is safer. So this is the answer. Next question is, why are bisphosphonates used in osteoporosis? Now bisphosphonates like alendronate, okay, or risedronate, these drugs, they inhibit osteoclast mediated bone resorption. Okay, and how does they do that? They bind to hydroxyapatite crystals in bone. So this results in decreased bone turnover, increased bone mineral density, stabilize bone matrix, and reduce the risk of fracture, right, in osteoporosis. So that is why bisphosphonate is used in the treatment of osteoporosis. They are the first line drug in post-menopausal and steroid induced osteoporosis, right? So this is the benefit of bisphosphonates. They are used in osteoporosis. They bind to the hydroxyapatite crystals in the bone and they reduce the osteoclast mediated bone resorption, and resulting in increased bone mineral density, reduced bone turnover, stabilization of bone matrix, and decreased risk in the fracture in osteoporotic patients. They are the first line drug in postmenopausal and steroid induced osteoporosis. So why is neostigmine preferred over physostigmine in the treatment of myasthenia gravis? Now myasthenia gravis is an autoimmune disorder in which there are autoantibodies against the neuromuscular junction, thereby causing weakness in the muscles and drooping of eyelids. Weakness in the muscle is the main feature here. Fatigue, drooping of eyelids is there, ptosis. Then in general the patient becomes increasingly incapacitated. So why is neostigmine preferred over physostigmine? So we understand the difference between neostigmine and physostigmine first. So neostigmine is primarily a quaternary ammonium compound, right? Quaternary ammonium compound, while physostigmine is a tertiary ammonium compound, right? And because of this difference, this does not cross the CNS and this crosses the CNS. Okay, so it does not cross the CNS, it crosses the CNS through blood-brain barrier and has CNS effects. So that is one reason why neostigmine is preferred in myasthenia gravis, because in myasthenia gravis we need peripheral action. This is not a disease of CNS. We need peripheral action at the neuromuscular junction. So what it does is that it reduces the action of acetylcholinesterase, and thus they increase the action of acetylcholine at the neuromuscular junction. So that is one reason. Second reason is that neostigmine is longer acting, right? It is longer acting, while physostigmine is shorter acting. So this is the main difference between both of them, because of which the neostigmine is preferred in myasthenia gravis. Why benzodiazepines are preferred over barbiturates as sedative hypnotics? This we have done earlier also. So benzodiazepines are preferred over barbiturates. This comparison we have done earlier also. So they have a rapid onset, they have a short duration, they have less dependence producing potential, and they have a specific antidote. Right? While barbiturates, they are longer acting and they have a dependence potential and no specific antidote. So in case of poisoning or overdose, we cannot treat barbiturate poisoning directly. Plus it has got a higher safety margin, while these have got a lower safety margin. Okay. The next question is why ethanol is used for the treatment of methanol poisoning. Now methanol, what happens is, methanol जिसको हम बोलते हैं देशी शराब या फिर कच्ची शराब, तो this is metabolized by the enzyme alcohol dehydrogenase, and this produces toxic metabolites which is formaldehyde and formic acid, which are toxic metabolites. And what toxicity they do? They damage the optic nerve, damage to the optic nerve, and sometimes death also. They cause severe acidosis in the body. So now what does ethanol do? Ethanol goes and gets metabolized by this enzyme, and when ethanol goes and gets metabolized by this enzyme, then it is a kind of competitive antagonism to methanol. So increased ethanol metabolism and reduced methanol metabolism. So जो methanol के toxic metabolites produce हो रहे थे, then they are not produced and the damage to the body is reduced. So that is why ethanol is used in the treatment of methanol poisoning, right? Next is why paracetamol is used for the treatment of organophosphate and not carbamate poisoning. Okay, so before that we need to understand organophosphates, carbamates. These are basically, what are they? Acetylcholinesterase inhibitors होते हैं ये, ठीक है? So what they do is that they increase the action of acetylcholine by inhibiting the cholinesterase enzyme. Now organophosphates and carbamates, they are usually found in the poisons like pesticides. Organophosphates, they bind irreversibly to the enzyme, okay, and carbamates, they bind reversibly to the enzyme, okay. Carbamates bind at the anionic site, while organophosphates bind at the esteritic site. So they bind at the anionic site of the enzyme and they bind at the esteritic site of the enzyme. So now paracetamol, it's a quaternary oxime compound. It reactivates, its main action is that it reactivates acetylcholinesterase enzyme, okay. Now what it does is it goes and attaches to the paracetamol, attaches to anionic site of enzyme and cleaves the phosphate bond, right, between the enzyme and the organophosphate. So this is the action by which it removes the organophosphate from the enzyme and makes the enzyme free and increases or reactivates it. In carbamates, now paracetamol carbamates में जाता है. So first reason is the anionic site is not free to attach. So anionic site is not free to attach. So that is one reason why they are not very effective. Secondly, they increase toxicity of carbamates. They increase the toxicity of carbamates. How? They potentiate carbamates. Okay, so that is the reason why paracetamol is not given in the treatment of organophosphates. It's given in the treatment of organophosphates and not carbamates, because it actually increases the toxicity of carbamates. It is known to potentiate the carbamates. The next question is, why is tamsulosin preferred over prazosin for the treatment of benign prostatic hypertrophy? So benign prostatic hypertrophy के patient में basically urination issues होते हैं. So because of the increased size of the prostate, the prostatic urethra is narrow, and because of that the patient has urination difficulties. Now prazosin is a alpha-1 blocker, right? So by acting on alpha-1, it is leading to smooth muscle relaxation and increased urine flow. It is, but tamsulosin, tamsulosin, it acts selective alpha-1A receptor blocker होता है ये. So it is a selective alpha-1A receptor blocker which is found in the prostate and bladder neck, right? So this leads to smooth muscle relaxation and increased urine flow. Secondly, no hypotension as is seen with prazosin, and better tolerability. So these are the reasons why tamsulosin is preferred to prazosin. Prazosin is alpha-1 blocker, so yes, it also produces efficacy, but अब हमारे पास we have got more uroselective drugs. So tamsulosin is actually said to be a uroselective It specifically acts on alpha-1A receptor, which is present in the trigone and the bladder sphincter area. And there, then it contracts the bladder muscles, relaxes the sphincter, and allows the urine to be passed. Secondly, it does not cause hypotension like prazosin, and it has got a better tolerability. Why antihistaminics are not effective for the treatment of bronchial asthma? Now, in bronchial asthma is basically an inflammatory condition characterized by involvement of mast cells, eosinophils, cytokines, leukotrienes, and not just histamine. So, bronchial asthma is a multifaceted illness. उसमें बहुत सारी और भी दूसरी चीजें involved है. And the second part is bronchial asthma has got bronchoconstriction, and this bronchoconstriction is not relieved by antihistaminics. So, besides histamine, so antihistaminics are not effective in bronchial asthma. What drugs do we require? Actually, we need bronchodilators and anti-inflammatory. These are the drugs which make the mainstay of the therapy of asthma. So antihistaminics are not effective in controlling the bronchial asthma. Next, why is morphine contraindicated in head injury? We have done this earlier also. Morphine is contraindicated. It's an opioid. First thing, it causes respiratory depression, right? So it can increase carbon dioxide and cause increased ICP, hypercapnia करके. It causes meiosis. So by causing meiosis, it can interfere with the neurological assessment, right? Secondly, third, it causes sedation and confusion. So in a neurological evaluation of the patient, these things can be a hindrance. They can complicate the monitoring. So that is why morphine is not used. It can even worsen the cerebral edema. So that is because of all these reasons, morphine is contraindicated. Next question is, why is a loading dose initially given for some drugs? Now, loading dose is initially given because first we want to quickly achieve the therapeutic plasma concentration where the drug will be efficacious. Efficacy depend करती है उसकी, right? Then secondly, if the drug is having a long half-life, so there it is given. And third thing, if the drug is having a large volume of distribution. So loading dose का जो formula है, loading dose is equal to VD into CPSS. So volume of distribution will decide the loading dose. A drug having a large volume of distribution will take time to distribute and time to build the effective level. So we give drugs by loading dose to avoid the delay in clinical effect, right? So we use a loading dose in some. The one example that we have is malaria. In malaria we give a loading dose. Then emergencies, right? Emergencies may we give. Now the next question is, why beta blockers are not preferred for use in diabetics? So understand, beta blockers, first of all, they block beta 1 and beta 2 receptors, right? Then so their first action is that they reduce the sympathetic symptoms. So due to hypoglycemia, when एक diabetes का patient है and he develops a hypoglycemia, so this hypoglycemia will result in some sympathetic symptoms, right? Sympathetic symptoms कैसे होंगे? Tachycardia होगा, tremors होंगे, palpitations होंगे, right? So what does all these symptoms beta blockers mask or hide or delay? So the symptoms of hypoglycemia in a diabetic mellitus patient are masked or hidden or delayed by the beta blockers because they hide or mask the sympathetic symptoms, and that can result in what? That can result in dangerous hypoglycemia that patient presents when the blood sugar level is very low. And secondly, they also prolong hypoglycemia. How do they do that? They basically block the beta 2 mediated gluconeogenesis. So that is why these drugs, they are not preferred for use in diabetics. You can still use cardioselective, which are basically acting on beta 1 receptor, cardioselective beta 1 receptor blockers, right? But not beta 2 blockers. So with this we finish the chapter, the video on explain why questions, which is mainly meant for the second MBBS students who are going to give their prof exams. These type of questions are very commonly asked, and I'm sure this whole video is going to be very useful for you students.